Hello, I'm Stacy Smith, and this is my physical assessment on my client. Do you consent to this exam?
Yeah.
Okay, starting with the cranial nerves. Cranial nerve 1 is the olfactory nerve. It's a sensory nerve testing for smell. Could you please occlude one nostril?
Alcohol. Alcohol.
Okay, cranial nerve 1 is intact. Cranial nerve 2 is the optic nerve. It's a sensory nerve. We'll be doing the Snellen chart for visual acuity, confrontation test, and the fundoscopic exam. And for the video purpose, the person will not be 6 feet away. Could you cover the last two lines?
Alright. CFDHJLTFPH. CFDHJLTFPH.
Okay, the patient has 20/20 vision. Now for the confrontation test. Get stand up. Tell me when you see my fingers.
I see it. I see it. I see it. I see it.
Okay. And for the fundoscopic exam. Going in laterally. Looking for the red reflex. And the retinal background, which indicates perfusion. It would be abnormal for me to see AV Nicky and cottonwood patches, which I did not see. His arteries and to vein ratio was 4 to 5. The optic disc was had sharp margins. It was a yellowish orange color. The physiologic cup was no greater than 2/3 of the optic disc, and the fovea and macula showed no signs of macular degeneration. So cranial nerve 2 is intact. Cranial nerve 3, 4, and 6 are motor nerves. It's the oculomotor, trochlear, and abducens. First, we'll start out with the 6 cardinal fields of gaze. Okay, follow my point. Okay. The corneal light reflexes, putting the light on the bridge of the eyes, and the Get at the muscles, no leg, lag, noted. The uncover test, normally this will be done for 30 seconds, and we don't want to see deviation of the eyes when taking the cover off. And the eyes did not deviate. For parallel assessment for roundness, reactiveness of the eye pupil, his eyes are symmetric and round. Now I will test for reaction to light, direct and consensual light. Okay. And accommodation. Okay. Cranial nerve 3, 4, and 6 is intact. Cranial nerve 5, the trigeminal nerve, is a sensory and motor nerve. First, we'll be doing the sensory nerve. The patient will distinguish between sharp and dull. Sharp, and that is dull. Close your eyes.
Sharp. Dull. Sharp. 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 Dull. Dull. Dull.
Okay. And for the corneal reflex test, I would take a cotton ball and press it against the patient's cornea, and the cornea would react. Now for the motor part, could you please move your jaw side to side? Okay. And palpation of the temporal and masseter muscles. Clench your teeth. And his motion on his mouth is a 5 out of 5, and they are equal. Now on to cranial nerve 7, which is the facial nerve. It's a sensory and motor as well. I will put something for the sensory part. I will put something on my tongue depressor, and the patient should be able to identify what it is on the anterior 2/3 of the tongue. What would you taste?
Salt.
Okay. So could you frown? Raise your eyebrows, puff out your cheeks, smile. Okay. Cranial nerve 7 is intact. Cranial nerve 8 is the acoustic nerve. Testing for hearing. I will start out with the whisper test. Could you occlude one ear and tell me what I am saying?
99. Oh wait.
Okay. Now for the Weber test. The Weber test is testing for conduction and sensory neural loss. In a normal person, the sound will lateralize to both ears. In the affected ear, if it lateralizes to the affected ear, that's conductive hearing loss. If it lateralizes to the unaffected ear, that is sensory neural hearing loss. Can you hear it?
I hear.
On both sides?
Mm-hmm.
Okay. So his hearing is intact. It lateralized to both sides. For the Renee's test, air conduction is greater than bone conduction by 2 to 1 in conductive hearing loss, and in sensory neural hearing loss, bone conduction is greater than air conduction. And tell me when you don't hear it.
When I don't. I don't hear it.
Okay.
I don't hear it.
Okay. So cranial nerve 8, the acoustic nerve is intact, and it is a sensory nerve. Cranial nerve 9, the glossopharyngeal, and cranial nerve 10, the vagus. Testing for swallowing and pronation and the rise and fall of the vulva. Also taste test with the 1/3 posterior tongue. Tell me what you taste.
Salt.
Okay. I would say I.
Ah.
Looking for the rise and fall of the vulva. And it did rise and fall. If it did not rise and fall, we would suspect any lesions or some type of neuro abnormality going on. So cranial nerve 9 and 10 is intact. The swallowing reflex goes with those nerves as well, but I'm not going to do that for the sake of the video. I will stick the tongue compressor back and the patient would gag. Cranial nerve 11, the spinal accessory nerve. Test the resistance of the trapezius muscle and the sternocleidomastoid muscle. So try to move your jaw. Okay. And try to straight shut. Okay. So cranial nerve 11, the spinal accessory motor is intact. Cranial nerve 12 is the hypoglossal. It's a motor nerve. Could you stick out your tongue and in your jaw? Put them in your jaw. Okay, that's the end of the cranial nerves. Now on to the HEENT pulmonary thorax assessment. First, I'm starting out inspecting the client's hair for texture, moisture, looking for any lesions, any indication of hair loss in the scalp, any inflammation in the scalp. The scalp is not edematous. Could you smile for me? The patient's smile is symmetric. Now I will palpate the frontal and maxillary sinuses. Is that tender?
Mm-mm.
It's tender?
Mm-mm.
Okay. And now could you open your mouth? Looking for any clicking in the TMJ joints, and I do not feel, and they are a 5 out of 5, and they are equal. Now onto the ears. Inspecting the ears, the auricles, and the pinna and the mastoid process for any lesions, nevi, any inflammation, irritation. Does that hurt? You feel any pain or tenderness? If it was pain or tender, we would suspect Otis media, but the client does not have any pain. And now for the tug test, I will manipulate the auricle, pinna, and tragus for tenderness. Does that hurt?
Mm-mm.
That hurt?
No.
Okay, no pain. And if it was any pain with that, that would be an indication of otis externa. And now, looking into the ear. Looking at the ear canal, looking for any redness, drainage. The tympanic membrane is pearly and gray. Conal light on the left side is at 7 o'clock. The right side conal light is at 5 o'clock. No drainage or redness noted. Tympanic membrane is pearly gray. It's not perforated. Also with the auricles and the handle of malleus and the process of malleus, if they were more predominant, that would indicate a contraction of the tympanic membrane or perforation of the tympanic membrane. Now onto the nose. Checking the patency of the nostrils, looking to see, checking for moisture and pinkness, looking at the turbinates. I was able to see the inferior and middle turbinate. The superior is not visible. For patency, could you occlude one nostril and sniff? Occlude the other nostril. And looking at his septum, it does not look deviated, but I will run my hand down. It is not deviated, it is midline. Now for the mouth. Looking into the patient's mouth for gums, looking at pink, moist, no missing teeth, no lesions at the roof or floor of the mouth. Lips are not cracked. Tonsils are not inflamed. The tongue is not swollen. So his mouth is completely normal. Now onto the neck. I'm looking at the neck, looking at any goiter, making sure it's symmetric, no masses visible, nevi or lesions noted. And now I will palpate the trachea, starting at the sternum border, making sure it is midline, and it is. The trachea is not deviated. And now I will go on and palpate the thyroid. So with the thyroid, it's not normally palpable. I will have the patient to swallow. Okay, turn your head to the left. I'm gonna displace it to the left. Hold your head down. Okay, swallow. And turn your head to the right and down and swallow. It's not palpable. Okay. For the lymph nodes, they should not be no greater than 1 millimeter. They should be soft and will not hard. So submental, submandibular, preocular, postocular, tonsillar, occipital, superficial, cervical, deep cervical, supraclavicular, and intraclavicular. And now onto the posterior chest. Looking at his chest, looking for any lesions, any nevi, no masses noted. Looking for scoliosis, lordosis, kyphosis, and none of that is noted. I'm going to palpate for tenderness. Are you tender? Any pain? No. Okay. And respiratory expansion. It is located at the 10th rib. Looking for good lung compliance. Could you take a deep breath? And with that, just looking for the separation of my thumb, which would indicate good lung compliance. For the CVA tenderness, put my hand over the kidney. And is there any pain? Any pain?
Mm-hmm.
Any pain?
No.
Tactile firmness, can you say 99?
99.
Okay.
99.
Okay. And with that, it's increased over areas of consolidation and greatest interscapulary. Now, percussion for dullness and resonance is normal. And the area of dullness would indicate increased consolidation. Hyporesonance would indicate emphysema or COPD, which I did not hear. Now on to auscultation. Listen for one full respiratory cycle. Okay, and what we're looking for is abnormal breath sounds, wheezes, rales, bronchi, bronchovesicular sounds will be heard in the mid-scapular area, vesicular lung sounds will be heard in the bronchial periphery, which I did not hear any abnormal lung sounds. Now for the anterior, looking at his chest, he does not have any lesions, nevi, pectoris excavatum, pectoris carinatum, which would be a protrusion of the chest, and the other would be a sunken chest. Looking at his respiratory rate, he's not using any accessory muscles. His breathing is non-labored. So I will start out by palpating for tenderness. The patient's a little ticklish. Does that hurt? Okay, that hurt. Does that hurt? Okay, and for respiratory expansion, just take a deep breath for me. Put my hand on the costal margin. Okay, and my hands did separate. That will indicate good lung compliance. Now for tactile firmness, could you say 99?
99.
Okay. In those areas, I did not hear any increased consolidation. Osculating, no, percussing, resonance is normal. Dull, if you hear a dull sound, that would be heard over an organ such as the heart, and the flat would be a bone. Now for auscultation. Okay, and I did not hear any wheezes, bronchi, no bronchovesicular sounds that will be heard in the main trachea bronchi. Also, vesicular sounds are heard normally in the first and second intercostal space. And going back to the posterior exam, testing for sounds like the bronchophony, the patient would say EE, and if I heard A anywhere, that would be an area of increased consolidation. For the whisper pictorically, the patient will whisper 99 or 123, and if it got louder or clearer, that would indicate increased consolidation. I will perform the bronchoscopy. Could you please say 99?
99. 99. 99. 99. 99.
And it did not get louder or clearer. Now on to the cardiovascular and peripheral vascular assessment. Could you please lie down for me? Just looking at the patient's chest for any lifts, pulsations, and heaves. I do not see any of that. Now with the six precordial points, the aortic at the second right intercostal space, pulmonary at the second left intercostal space, Erb's point at the third intercostal space, tricuspid at the fourth intercostal space, the mitral located at the fifth intercostal space, left mid-clavicular line. Also, the apical pulse is heard here. If it was lateralized, that would indicate an enlarged heart. And the epigastric is the sixth space, not sixth space, below the xiphoid process, left mid-clavicular line. S1 is heard at the mitral area at the apex. S2 is heard at the aortic at the base. S3 for mitral valve prolapse is heard at the mitral area in the left lateral decumbent position. Split S1 is heard at the tricuspid area. Split S2 is heard in the pulmonic area. It may vary with inspiration. This is the only one that varies with inspiration. And mitral valve prolapse and aortic stenosis is heard during systole. To distinguish between those two, the squat says the patient would squat over the apex, and if the loud sound diminished, that would be mitral valve prolapse. If it got louder, it would be aortic stenosis. For Valsalva maneuver, the patient will bear down if the sound gets louder. That is mitral valve prolapse. If it gets lower, that is aortic stenosis. I'm looking for any clicking. So could you please bear down? Okay. So now I will auscultate with the diaphragm of my stethoscope, the aortic, pulmonic, tricuspid, and mitral. Tricuspid. And with the bell, my left lateral border. And the mitral. Okay, and I am going to have the patient lay on your left side so I can listen for S3 for a mitral valve prolapse. And hold your hands up with the bell of my stethoscope. Looking for any murmurs, no murmurs, or gallops noted. And now, could you sit up? I'm gonna listen to your left sternal border. The diaphragm. And no murmurs are noted. Okay, now for the pulses, can you lay back down? Patient will hold. Sorry. Patient will hold his breath, and I will listen in 3 places. Turn your head and hold your breath. And turn to the other side. And for the abdominal aorta. Renal. Iliac. Femoral. And your radial and brachial. Okay. And now for the assessment of the pulses. Pulses are graded from 0 to 4. 4 being bound and 0 being no pulse, and 2 being normal. Okay. And the popliteal, you would lift your legs up. I'm gonna take your socks off.
Pull down low, put them all the way off.
Okay. Posterior tibial and the dorsalis. Okay. And looking at edema, dependent edema, he does not have any edema, no pitting. That would be graded from 1 to 4. 1 being able to recover quickly, 4 being able not to recover quickly. Anasarcoedema, generalized edema, cerebral edema, edema of the brain, pulmonary edema, which he does not have any. Now tested for warmth, skin turgor, capillary refill should be less than 3 seconds. Don't see any clubbing. Clubbing would indicate a decreased oxygenation. Now for the upper body, warmth, skin turgor, and capillary refill. No clubbing in the upper area either. Now, for the abdominal assessment, I'm looking at his abdomen, looking for any lesions, nevi, pulsations. No predominant pulsations is noted. Now I will listen for bowel sounds. When ascending order of normal active bowel sounds is 3 to 35, hypoactive less than 5, and 35 is greater than hyperactive is greater than 35, and berbignum, which be increased gas bubbles. Okay, and now listening for friction rub in the spleen and epigastric area. If this sound was to be heard, that would be suspected maybe a liver biopsy, tumor, chlamydia, or gonorrhea infections. Also, if there were any predominant pulsation bruits that would indicate hepatic carcinoma. No grating sound noted. I know grating sound is noted. Now for the venous hum, it's a soft systolic and diastolic hum heard in the epigastric and hepatic area. If this was heard, it would indicate collateral circulation or hepatic cirrhosis. Okay, and I did not hear a hum. Now on to percussion of the liver. The liver should have a dull percussion, and the spleen should have a timpani sound, and it's also heard of the gastric area and the gastric area and the spleen. Okay. And did hear a timpani and dullness sound. Now, looking at the abdomen before I'm assessing for aortic aneurysm. The abdomen does not have any predominant pulsations. If it did, and we suspected aortic aneurysm, and the client was having symptoms, we would not palpate. I would start with a light palpation of the abdomen. You feel any pain? Any pain or tenderness? Deep palpation, any pain or tenderness? Okay, and now for organomegaly, I will be palpating the liver from timpani to dullness and finding the liver. You stop when you get to the dullness and going from superiorly. And if the liver was enlarged, we would just make sure that it was sharp and smooth and non-tender. Could you take a deep breath for me? Any pain or tenderness?
Mm-mm.
No. And now for the spleen. Going from cardiac dullness to tipping it into the trough space. And the spleen is located in the 9th, 10th, and 11th intercostal space. Could you bear down? The spleen or the liver is not palpable, which is normal. Now on to umbilical deviation. The upper is T, 8, 9, and 10. And we're just looking for the umbilicus to deviate to the stimuli. And the lower is T, 10, 11, and 12. And this is tested for spinal nerves in which his is intact because he did react. Now, if the patient came in for right-sided pain suspected of appendicitis, the test that would be ran the Rossfine test, pressing down on the left vertebra. Do you have any referred pain? No. The Sosa's test, raising the client's leg, seeing if he has any pain in the right quadrant. Do you have any pain? No. The Obstrators test, lifting the client's leg and maneuvering it to see if he has any pain. The rebound tenderness, I will press in this margin, this area. Do you have any pain? No. So his test is negative for appendicitis. For the cholecystitis, putting my thumb in the costal margin. Do you have any pain? And that's a negative Murphy's test. Now on to the musculoskeletal.
Sit up.
Yes, you can. For the fingers, this is flexion, extension, abduction, adduction. For the wrist, flexion, extension, radial deviation, ulnar deviation. For the elbows, flexion, extension, pronation, subnation. For the shoulder, flexion, extension, circumduction, abduction, abduction, internal rotation, external rotation. For the neck, rotation to the right, rotation to the left, right lateral bend, left lateral bend, flexion, extension. For the spine, this is flexion, extension, rotation to the right, rotation to the left, right lateral bend, left lateral bend. The hip, flexion, extension, abduction, adduction, external rotation, internal rotation. For the knee, flexion, extension. For the plantar flexion, dorsiflexion, inversion, exversion. And for the toes, flexion, extension. Now on to the knee stability test. You lay down for me. Tested of the LCL with the various test. Pulling against the LCL and moving it medially. For the MC, do you feel any popping or pain? For the MCL, pressing against and moving laterally. Do you feel any pain? For the anterior drawer test, for the ACL, anterior cruciate ligament, pulling against the tibia, against the fibula, do you feel it? I don't feel any popping or dislocation. For the posterior drawer test, pushing against the tibia, against the fibula, no popping or displacement noted. For the McMurray's test, I will extend and externally rotate. Do you feel any, that's testing for meniscus tear. Do you feel any pain? And for the MCL is anteriorly and medially. You can sit up for me. The carpal tunnels test, just tapping the median nerve between the thumb and first and second fingers. Do you feel any pain or any sensation? Okay, and it's the Tillis test. The Phalen's test, could you do like this? You feel any pain or sensation? Okay, so he has negative tests looking for inflammation and pain and sensation in that median nerve. Could you stand up for me? The rotator cuff, you turn around. Bringing his hand back. Palpation of the 6 muscles, the supraspinatus, intraspinatus, tenacious minor, and the subspinal. Do you feel any pain or any sensations? Okay. The athlete scratch test, could you use this arm, try to scratch the top of your back and the below your back, and look for range of motion. And then the other arm, as far as you go. Okay, and below the athlete scratch test is negative. And then the drop test, hold your arm 90 degrees and drop it slowly. Okay, and if this was positive, his arm would just flop down. So could you turn like you're emptying some cans, and do like that, and try to, okay, and then like this. Okay, and now for the scoliosis check, could you bring your hand out, looking for one arm, I'm sorry, bowing of the back, and put it down. No bowing of the back. His shoulders are symmetrical, looking at the iliac crest, no curvature. Could you bend down for me? Just bend. Yeah. And his spine is midline. Sorry. And for lower back pain, just palpation, the paravertebral muscles. Do you feel any pain? Okay, and the spinous points. Any pain or sensations, tenderness? Could you lay back down for me? And look, we're doing the straight leg raise, looking for sciatic nerve pain that radiates from the back onto the leg. Do you have any pain? Okay. And cross grip leg raise. Do you have any pain on that side? Okay, you lay it back down. And range of motion was done early, and the tendon reflexes started next. So could you sit back up for me? The supinator, looking for flexion of the supinator, C5 and 6. Okay, and just looking for contraction and flexion of that muscle with the brachia. Okay, also the C5 and 6, and these are graded 0 to 4, 4 being hyperreflexia, 0 being hyporeflexia, and 2 being normal. In the triceps. Okay, and the knee, looking for lower leg flexion. This is T23 and 4, and the ankle behind the Achilles is S1. Okay. Now on to the Bradinsky reflex. Could you lay back for me? Palpating, looking for any rigidness and lower abdominal, not abdominal, involuntary movement of the lower leg muscles. The Bradinsky and the foot should flex. Okay, and we should not see any fanning in adults. That's normal in babies. If it was done in adults, that would indicate some type of neuro abnormality going on. And the kernings up. Does that hurt? Any pain? Okay. And now on to motor. Could you stand up for me? And I'm gonna get you to walk on your tiptoe. Walk normally first over here. It goes that way. And then on your tiptoes. And then heels. And then heel to toe. Like heel to toe like that.
Oh.
Okay, and that's all. And we're looking for like any swaying, his posture. He was able to keep his balance. We're going to sit back down. Rapid movements, alteration movements. Your fingers, thumb. You close your eyes, and then back of your hand to your knees, and your heel to my hand. Multiple times, okay? And he was able to do that. Now, hold your hand up and touch my point. One more time. And finger to nose. Twice. And heels to shin, skin. Okay. And now the lumbar kiss. Could you stand up? And here I'm just looking for any swaying that he may have. He's unable to keep his balance, but he's able to keep his balance. And the pronator drift. You hold your hands out. And looking for any drifting of the pronator, any weakness that he may have in which he does not. Just sit back down. Tell me how I'm moving your hands.
Up, down.
Okay.
Side to side.
Okay.
Up, down. Side to side.
The sterigenosis. Tell me what I have in your hand. Close your eyes. What did I put in your hand?
Cotton ball.
And what did I draw in your hand? Graphic stitches.
Yes.
Okay. And that is the end of my exam. You can scan the room again.